Good afternoon, everyone, and welcome to Dynamic Careers in Aging. My name is Cassie Kramer, and I'm with the Older Adult Behavioral Health Network at the Massachusetts Association for Mental Health. We put this event together in partnership with the Schools of Social Work at Boston College, Boston University, Salem State, and Simmons. We're happy that so many of you could join us today. Like many people, I fell into a job in the aging field, but once there, really discovered a passion. Our hopes are that you will come away with some ideas about the range of positions in the field, some contacts, and some meaning and value of the work. Before we get started, I'd like to remind you that today's webinar is being recorded. We'll send you a link to the recording when it's available next week. We have many people here from different agencies. So I would invite you, you're always welcome to put your contact information or job source resources in the chat. But I'd like to go ahead and get started. So without further ado, I'm going to turn it over to our first speakers. That is Amy and Edith Edmonds.
So happy that you invited me to participate in this effort. 98 years old, and I feel confident and can do this. And I'm happy to be a part of this participation. I love to sew, and I have sewn quite a bit of the Underground Railroad. I have made 3 wall hangers and 1 full-size quilt. My social worker, I have social workers who are working with me, and my daughter as a caregiver. She lives in the home with me that my husband built in 1954. So I'm just so happy that she's here with me.
And I'm going to clarify some of the roles that the social workers play in my mother's care. The first role is through the state organization. We are in the Commonwealth of Virginia. And so we have a social worker that oversees the management of her designation as a dual enrollee in Medicare and Medicaid. We also have a social worker through our insurance provider, United Healthcare, and they manage her community health responsibilities. And then we have a social worker that we interface with occasionally during hospitalizations. And then the fourth social worker we encounter with her primary care provider. And she performs annual needs assessments. The hospital social worker generally manages any new or additional needs that she might have post-discharge. Currently, we have not had to tap her resources. We most frequently utilize the services from the United Healthcare coordinator, and she has become more of my go-to person. I can text her, and I really appreciate the prompt response. I'm new to the caregiving role, and so I'm full of questions. And I would like for Mom to share what it is that she appreciates most about this team of care workers that she encounters.
I really, really appreciate the caregivers, the social workers who supports me with respect to my ability to control my finances and my life, end of life program.
Yes, because for my mom, she made many of those decisions about 40 years ago, and that has been a tremendous blessing for our family to not have to make those choices for her, and it has really provided our social workers with a guidepost of how she wants to live her life, and we've been able to execute that plan that she set forth. And so in the future, we hope that social workers will enhance their own work experience as well as their client experience by creating communication networks among themselves. It gets really wearisome having to repeat the same information over and over, and to not have social workers informed of what other social workers are doing in separate silos. And so as a caregiver, that is very draining because our day is already full, and it's like, I just answered that last week. Why are we going over this, and why don't you already know that? And so I think there's a tremendous opportunity for more communication among the social workers. And I would like also to see much more informed use of digital home monitoring for aging patients. I think that could really be a huge asset, both for caregivers and patients, and for social workers being able to maintain appropriate data to make more meaningful decisions. Thank you.
Thank you so much. And now I'm going to turn it over to Jamie Jensen.
I'm here with my colleague Sharon Sandalo as well, another BC grad. So thank you for having us. Unfortunately, I have to duck out in a little bit, so I'm going to talk quickly and then turn it over to Sharon. But thank you all so much for having me. Sharon and I work at the Brookline Council on Aging at the Brookline Senior Center, right up the street from BC. In terms of my career path, I graduated from BC in 2011 and went right into working into the aging field at a local rehab and long-term care setting, which gave me a lot of experience in that type of setting. So I was there for a couple of years and then transitioned to coming here. The Brookline Senior Center was actually my undergrad internship. I went to Wheelock for undergrad and I had an internship here. This is my BSW internship. So that is my recommendation that I always say to potential social workers going into the field, is to definitely maintain those networking. Definitely don't burn any bridges. Keep your networking options open, because you never know what can come up in terms of future jobs. I kept in touch with our director, was able to get a job here, which really has been my dream job coming back here. I do have experience also in a mental health setting, as well as I mentioned, with long-term care and rehab settings. I also work part-time at another senior center where I run a program for folks with early stage dementia and their caregivers. It's a social program, very unique program called Continuing Connections. So I do that. I've been doing that actually longer than I've been here at the senior center. But I've been here about a decade now, and I started out in our home care program, matching home care workers with seniors in the community. We also run an equipment loan program where we give out used medical devices, walkers, wheelchairs, etc., to seniors in need. And also a parking program. For those of you familiar with the town of Brookline, parking is not easy. So for caregivers who are looking to park on the street, we issue parking permits to those caregivers. So those are three of one of our many unique programs here at the Brookline Senior Center. We also offer programs here where we are community centers. So people come here for regular programs. And that's the role that I do now, is providing all those different social educational programs to folks here at the Senior Center. So those are some of our general programs that we offer. But Sharon, here's one of our clinical social workers as well, and she can speak to what the clinical social work staff does as well.
Hi, everybody. Thank you so much for hosting us. As Jamie said, I am a clinical social worker here at the Brookline Senior Center. I love my job. I love my colleagues. And I am very fortunate to be able to do what I do. I have a caseload. Anyone who lives in the town of Brookline who's 60 and older gets to use us, the social workers. I have a very varied caseload. I primarily actually do therapy for my clients, and it's a very diverse group. I'm ranging from age 60 to, late 90s. And people just with your regular, problems that we all experience, depression, anxiety, issues. Some of my clients have cognitive issues, dementia, a lot of physical problems, and just, difficulty transitioning. It's a very, very wonderful caseload, and I'm very fortunate. I either make home visits, or they come here to the senior center, or I speak with them on the phone. Also, I do some casework also, but my clients happen to be primarily, I see them for mental health issues. I took sort of an unconventional path. I also went to BC. I graduated in 2019. I was a stay-at-home mom for many, many years. In my 20s, I was in a doctoral program in clinical psychology, but I never practiced. I stayed home with my kids. And then due to a change of circumstances, I went back to school and got my social work degree. And I didn't major in, I didn't do my internships at BC in older adults. I was a clinical concentration. I had 2 different internships, which I loved. And I just sort of fell into this, and I love it. I really feel that I'm helping people. We have a lot of versatility. We have a lot of flexibility. We have a lot of autonomy. I also run 2 groups, which I really enjoy. Anyway, I can answer questions for people later on. Thank you.
I was going to say, do you want to mention the type of groups though?
Oh, sure. I have run a resilience group, something that I'm very interested in and people are pretty enthusiastic about, and a caregiver support group I'm about to start. So
Sharon speaks to obviously the variety of different things that we have here and that social workers can do here. We have a lot of social workers on our staff, but obviously Sharon and I have the exact same degree, but we do very different things. And that's what's so nice about being in the field of social work. Our director actually is a social worker as well. And she obviously does a lot more administrative tasks, budgeting, and a lot of the politics that go into being a director. We obviously, Sharon's one of our big caseload of, I shouldn't say caseload of social workers, but colleagues that are all clinical social workers who do the home visits and things like that in the town of Brookline. But then we also, have folks that run other groups here. We have social worker does a mindfulness group. We can be really creative in terms of the different groups that we offer here, which has been wonderful. So variety, I would say, and I don't know if you agree, is definitely one of the reasons that I went into social work. Is just the amount of different things you can do. No day is ever the same. There's certainly some black and white things that are always on the schedule. Let's say, there's a hoarding task force that Sharon is on with some of the other social workers. There's a lot of interagency work within the town itself, which is wonderful. And there's a lot of stuff even within the building that's great in terms of the offerings that we have for folks, really on every level. So that's what's really nice about social work as a whole, but also in terms of working with an aging population. There's so many of them that are in need. So, plenty of jobs out there, certainly. But also they are some of the most kind, warm-hearted people you can ever meet. And certainly anyone, there's certainly a lot of issues that we deal with, a lot of challenges, in working with people's families is great, but there's certainly a lot of variety in terms of the clientele themselves. And really the sense of humor that they have is amazing. It's just, they really are so fun to work with. There's never a dull moment. You're never bored. never. So there's just a lot to do and see and learn all the time. So again, similar to Sharon said, happy to answer any questions.
Yeah, and I will put in the chat the job board for the Mass Councils on Aging. Every area has a senior center, city or town. So you can see what's currently being offered or check back there anytime for new openings. With that, I will turn it over to Robin Collins.
Hi, my name's, oh, sorry, I thought I muted myself. My name's Robin Collins. I am with Mystic Valley Elder Services. We are designated as an ASAP, an Aging Service Access Point in the state of Massachusetts. And we offer a variety of services such as, traditional home care services. But my role is in the protective services department. So I am an investigator of self-neglect and elder abuse. So I'm working directly with the seniors and I absolutely love what I do. I have had kind of every role, well, not every role, but a lot of roles within Mystic Valley. I did traditional case management and working with those who were enrolled in the SCO program, so senior care options. And that was more of like a managed care plan. And I have volunteered as a money management volunteer. That was a lot of fun as well. Really how I got into elder services, like Cassie was saying, was completely accidental. My undergrad degree was actually in criminal justice, and I was just volunteering at my local senior center in order to get like yes hours for school. And I really fell in love with the population. And I started with the senior center and then got into Meals on Wheels, which introduced me into the world of the ASAP. So I kind of just landed here by accident and really found what I love. I'm currently a student at Salem State University in the master's program. So I'm very excited to continue to move forward and hopefully continue to move forward in my career. Yeah, I mean, if there was any tips I had for people who were entering the field, I'd say the biggest thing for me has been like to really listen to the elders and listen to their stories. There really has been like a plethora of knowledge that I've learned from the seniors that I work with and their caregivers. So it's never a dull moment. There is always something to learn, and I'm happy to answer any questions as well.
Thanks so much. And I will now move to Joan Hyde.
Well, like Sharon, I'm an accidental social worker. I started, I have a PhD in literature and psychology. I was in the second year of my postdoctoral internship when the psychology board changed its mind and said, no, that's not the right doctorate for our field. And so I became a default social worker. I applied, I got a license, and I've been licensed ever since. That was in about 1979. The next thing that happened is, and I really knew that I did not want to be a psychotherapist with middle-class people. I was tearing my hair out. So then my grandmother and my husband's grandmother developed real Alzheimer's, diagnosed Alzheimer's, and they were some of the first older people to have that diagnosis, because until 1978, 79, and a lot of you don't even realize this, Alzheimer's was never a diagnosis for people 65 and older. It was just called senile dementia. And research out of the University of Massachusetts Medical School in Worcester determined that they are essentially the same disease. So when I started out in this field, people didn't even know how to spell Alzheimer's. In fact, when I was studying for my psychology boards, there was one small paragraph and it said something about Alzheimer's, and it said, you may never see this in your entire practice. That's how much the world has changed in the last 45, 50 years. Well, now I'm very comfortably semi-retired, and I'll tell you what I'm doing now. I'm working on a study of robotics for people with dementia in residential facilities. That the little robot walks in and it has a computer and people can play games, they can talk to their families remotely. And the next thing we're going to do is provide that for people with dementia, with delirium in hospitals, to help engage them and help them stay comfortably in their beds and not pulling out all their IVs. And that's going to be a very exciting company once we get that done. I am a serial entrepreneur. So I started out with being a caregiver, and that's when I learned that people who have dementia can be some of the most delightful people that you're ever going to meet. They're forthright and they're right there in the present. What more could you want? So I was a caregiver for my husband's grandmother, and I had 2 small kids, and I was volunteering at what had been the Massachusetts Society Against Dementia, which then became the Alzheimer's Association. Actually, it was first called ADRDA. I don't know how many of you know that, the big Alzheimer's Association. It was Alzheimer's disease and related dementia. And so anyway, I became the director there. And they said to me, your first job is to raise enough money to pay yourself. So if you're going into social work, who knows what's going to happen? And many of the jobs are not particularly well paid, but I did raise enough money. I wrote a lot of grants. I learned how to write grants. And I also became a researcher at UMass Boston in the Gerontology Institute, where, for instance, I helped write a book called Staying Put, Adapting the Places Instead of the People. And it was one of the first books to bring together the need for adaptation for older people as well as people with disabilities, and made the case that we're all the same population. Eventually, I started 2 different companies, 2 different successful companies, one of which was developed the first assisted living for people with dementia in Massachusetts. And most recently just sold, but I'm still a consultant to a company in New York State that manages operations for assisted living for people with dementia. And we've come a long way, baby. We can now really create a world that is so dementia friendly that I'm like, okay, just wheel me in when I'm ready and I'll be good to go. I'm once again happy to answer any questions, but all I can say is social work has taken me a long way in the world of aging services, and I encourage people to join us in this endeavor.
Thank you so much. And I'm going to move to, I hope I say your name right, Karina Ladette.
Thank you. Yes, my name is Karina. I'm a social worker at McLean Hospital, which is a psychiatric hospital. I've always had interest in psychiatry, and undergrad did, of course, the psychology degree. I came to work at McLean and was involved in their research program and then in some of their DBT and more cognitive behavioral therapies. And after a while, I discovered I wanted to return. I had done some work at Brandeis University on their memory and cognition lab. And I've worked with a lot of elders there. It was time for me to go back to school and get my master's, and I was very fortunate to end up at BC. And I did choose the older adult track because I knew that was a population I liked, and I was hoping to combine the clinical psychiatry, psychology piece with the older adult piece. And certainly that has been the opportunity here at McLean. I work in an older adult unit. So there are 2 units. One is 55 plus for mood, anxiety, and other disorders. And the other is a split unit where half of the clients are people suffering with acute symptoms of their dementia. So usually untreated dementia, behavioral problems, things like that. Where we provide structure and relief and medication and the hope to return back to a life that can at least be somewhat enjoyable. And then specifically on my unit, though, we work with people who are struggling with everything from grief because of the multiple losses that they've had, the accumulated losses they've had in their life, people who struggled with retirement, people who have long-standing chronic illnesses and carry this amazing history of being treated in a very complicated, messy, and sometimes wrong system. Part of the process they may have been through is deinstitutionalization, where they actually lived in a facility for many years as a young adult. And then were asked to return to the community, sometimes with success, sometimes not. And you get to meet every walk of life, and every, we may have a homeless person next to a millionaire on the unit. It's like working in any hospital. You are able to meet all kinds of people, which is really one of the things I love most about working in aging, is all the personalities and all the stories you hear. There are these amazing stories that are untold, and to be able to sit and listen to someone. Of course, there's the practical piece of working in a hospital. You have a lot of opportunities for interdisciplinary interactions, so working with occupational therapists, physical therapists, doctors. In our area, we are really lucky that we have a lot of Boston hospitals that are leaders in the field. So you can be on the cutting edge of research, or you can be on the cutting edge of technology, like Joan was talking about, or Amy mentioned the need for better integrated medical records, and I so agree. There's a lot of possibilities and areas to go into. You're also always collaborating with people like Mystic Valley Elder Services in order to get supports back into the home. One thing that I would say is to take care of yourself. It is a tough field, and it is a wonderful field and a rewarding field. And I think you can do your best if you, as a clinician, are taking care of yourself. And certainly that's something that through being in this hospital setting, I've been able to work on committees that do things to take care of clinicians as well. So just a little plug there for self-care. Thank you so much for inviting me and letting me be part of this. Take care.
Thanks so much. Wow, it was really great to hear from each of our speakers about the perspectives they bring and the work they're doing. And I'd like to open it up for questions. And I'm also going to be putting some resources in the chat. I know there's some other people here from different schools or agencies. So if you'd like to jump in, I invite you to do that too. Liz.
Yeah, I am about to graduate in May with MSW from Salem State, and I interned this last year at a nursing rehab facility, nursing home / short-term rehab, and I think I had expressed interest in older adults, and sort of that's where they put me, and I think it's been fun, and I've enjoyed a medical setting. It was a bit unexpected to end up there. I guess my question is, I'm kind of trying to decide like where I want to go from here. And I guess I get a little worried about like growing in my clinical skills, like with anxiety, depression, or substance use, because it just seems like a lot of the jobs that are available tend to be more like on the medical side, or like maybe the places that serve older adults in mental health capacity seems pretty limited. Whereas like, I feel like the nursing rehab tends to be a lot of openings there. So anyways, just any advice about kind of growing in my clinical skills? Like I haven't worked in interned in a mental health setting. And I think I'm just curious like how people have grown in those skills and where they got that. Was it all by experience, or I don't know, that's just.
Okay, I'm going to jump in here because the Older Adult Behavioral Health Network has been advocating for years to develop the elder mental health outreach teams. And they exist now through about half the state. And actually, they're going through reprocurement where agencies are likely going to be starting new elder mental health outreach teams. And generally, they're placed out of the Aging Service Access Point Network. So that would be a great place to look and start. I will put the link where you can locate your local or closest aging service access point. Yeah, a lot of them are hiring elder mental health outreach teams. I see Courtney is here. I know she's hiring one. And I know Robin spoke to the experience she got. I also worked in protective services, and that actually is a great place to learn and see a lot of different people with different behavioral health conditions as well. But I'm going to let other people jump in too.
Yeah,
Go ahead. Sorry, Ambita.
Oh no, I was just going to jump in. I think what's confusing is every ASAP has a different title for those positions, and each position looks a little bit different. So I think it's going through each of the ASAPs and trying to understand like what are their MSW clinicians doing. Some agencies will call them mental health case managers, some agencies will call them clinical case workers, some agencies. So there's really no like formalized title, even though all the ASAPs are doing the same thing, but every ASAP has a different title, and the responsibilities might be slightly different by each ASAP. So
That makes a lot of sense. Yeah, thanks.
I can speak to that as well. So at Mystic Valley, especially in PS, we work very closely with our clinical department a lot. And we have one of those mental health outreach workers positions. And it's awesome. She's great. She goes out and does a lot of work in the community and going to the local senior centers and doing a lot of that. But most of the time, our clinical caseworkers are teaming up their clients with therapists and stuff. So if you were looking to do more like cognitive behavioral therapy with elders or something like that, that wouldn't really be the role, but you get to see such a scope of the collaboration between agencies when you're in one of those clinical caseworker roles.
I'd like to say that I do actually a lot of CBT work with my clients. I'm very fortunate to to have the mental health training from my psychology degree. And at BC, when I was in the social work program, I took a lot of clinical classes. And I've been supplementing it with, I'm continuing my education through CE classes, focused a lot on clinical skills. And I continue to learn. So they're out there, and my role is mostly a clinical role, and I love it.
Yes, that's like the councils on aging out of it too. A lot of the councils on aging have mental health positions. I think increasingly more so. So you could find those on the Mass Councils on Aging job board, which is in the chat, as well as you might want to check out. I'll put the link for the senior care options programs and PACE programs. They are often also hiring in mental health roles. And yeah, I also got a lot of training from CEUs. I took a certificate program in art therapy and the mindfulness-based stress reduction, both of which I use a lot with the older adults I work with.
Very helpful. Thank you so much.
I guess a question that I have is more centered towards those that do group work with elders, and like maybe a little bit more about how you got into that, and how if the different topics of these groups come from a personal passion or something like that. Thank you.
Certainly in the hospital setting, there is group therapy. I'm actually in this particular hospital setting there, the social workers don't do the group therapy there. It's a lot more case management. But there is such an interest in terms of people noticing the importance of speaking together as a community, or being able to talk with people who have like struggles and like backgrounds and experiences over time. So we have a variety of groups on the unit. Some of them are more music and hobby based, and other ones are more CBT and the therapeutic treatment based. A lot of people are looking for outpatient groups. So if there are clinicians in the audience who are doing outpatient groups for caregivers, and also for people perhaps who are early on with a dementia diagnosis. I was part of an outpatient group here that was working a little bit with the experience of being diagnosed with dementia and not being judged just for that you aren't just that guy's dementia. That guy is somebody was an engineer and has 2 lovely grandchildren and has a thriving life, even though he may have some cognitive difficulties. So there's lots and lots of interesting topics out there. And I want to say that dementia group was virtual. We got everybody to be virtual through the pandemic. So there's a lot of opportunities to use technology to bring people together when transportation is a huge issue. So that was a little bit too much, but there you go.
Thank you. I appreciate it.
Joan.
Suggest to almost anybody in the field is, if there's something you want to do and you're in an agency or somewhere where that's not on offer, is learn how to write grants. Because then you can supplement the programs at your agency with additional programs that you have a fire in your belly to do. And people are almost always willing to let you do it. Write a grant on the side and get some money to do something important.
Absolutely. Yeah, that's great advice. And I would also say, actually, it was my experience in protective services and seeing just all the unmet needs that led me to kind of pursue advocacy. And now is a really exciting time for advocacy. I'll put the link in the chat to a group that I work with a lot. It's called the Massachusetts Dignity Alliance. During the pandemic, actually, a lot of people came out of retirement because they were so horrified at what was happening in nursing homes, that they came together to start advocating for nursing home reform, expansion of community-based options, and actually a really exciting legislative agenda. And that's kind of a group that's led by both the disability community and kind of aging community. So it's a great group.
Wanted to call out that there's a question or comment in the chat from Nicole about, has anyone worked in end of life and palliative care space? Love to hear about the experience and what they liked or did not like about that work. I don't know if anybody here on the group can speak to that.
Joan?
I actually can, because one of the things we developed in our first assisted living was what we used to call, we called it the end stage program. Needless to say, for marketing, that wasn't the greatest name. So we changed it to enhanced assisted living. And in the company I'm involved with right now, we're licensed by the state of New York to do, they took on our nomenclature, interestingly, and they call it enhanced assisted living license. And we regularly do end of life. We refer people to hospice. Hospice comes in and sets it up. And I have to say, one of the most meaningful parts of my work in my companies was to sit with people while they were dying, and sometimes even after they died, until the family could come, and be there for people with dementia who are reaching that very last stage, and just hang out with them. And there are so many more services now than there used to be that help people go into those last weeks and days than there ever had been before. And it's a real honor to be there with people and their families during that very meaningful time of life.
I'd like to add on to that. I think that for my mother and our family, it was very significant that an older sister of my mother was involved with adult care about 40 years ago, and it was the feedback that she shared among our family that helped us to embrace end-of-life decision-making many years before my mother reached the age of 98. And it was because of those decisions that we made 40 years ago this has been such a smooth transition for us. And we lost my father about 8 years ago. And to have walked that walk with him and seeing how those early decisions really made the final decision so much easier. And so I'm speaking of, my father had a do not resuscitate. My mother has a do not resuscitate. I lost a sister to breast cancer. She had a do not resuscitate. And that's not a conversation that I would particularly like to have with my mother now at 98, but it was way cool to have that conversation when she was 50, 60 years old, and then to have lived our lives and to see how impactful that was for other family members. It really gives us the confidence to really lean into that and to look forward to that. And even quite recently, as my mom is starting to have some medical challenges, because we know that she doesn't want to be resuscitated, then that helps us to make other medical decisions to support that. So she's very comfortable with saying, no, I don't want to have an invasive procedure. No, I don't care if I have a bleeding ulcer. Let it bleed. I'm cool with that. I'm cool with that as long as it's not hurting me, and and there's no pain. She's very mindful of the time that it would take for her to heal, and what's going to be worse, dealing with the bleeding ulcer or trying to heal from the surgery that would result from that. And so it gives us a tremendous sense of empowerment to have social workers to support those decisions that were made. And I would say for social workers, don't get fixed in this box that end of life care is something that only happens to people in their 90s. You really should be talking to people about making decisions for end of life care when they're in their 40s and 50s. People need to know when they're 50 and 60 years old how to manage their finances, what they need to move out of their name so that there's no discrepancy. Don't wait until you die to pass on the inheritance. Give it to your children now. What's the big deal? Sign the house over to your daughter, sign the house over, so that once you get in need of those services, there's so much drama that we don't have in our lives right now. It's really great to just be able to focus on her care, to not have to sweat the small stuff, to not have to wonder, what am I going to do with the house? What am I going to have to do, with this and that? And what do I tell the doctor? And who's going to take responsibility for taking her off of life support? We don't have to have any of those conversations. And that is such a blessing, such a blessing. And so social workers, you have an opportunity to do really important work, really life-altering work that makes a huge, huge difference. And I would encourage you to have these conversations early with your clients, and it will take the stress off of you too, because you don't want to be caught in a box, with a family having to bring up those kinds of concerns at a really high pressure and intense moment. So thank you.
I'd like to add to Amy's point. What I was going to add initially was I feel like the worst part about working with people at the end of their life is when you get those messy legal situations because somebody doesn't have their healthcare proxy or POA. And, with protective services, one thing that I know, fortunately, I haven't had to go through the proceedings myself, but I've had to see, guardianships and conservatorships and, truthfully, like I think I was 24 when I started at Mystic Valley. One of the first things I learned and did was I went to a lawyer and I got myself a healthcare proxy, a will, and a POA. Because it is really traumatizing when you see someone work their whole life and they have to go through a court system in order to be able to make basic decisions about transferring from one hospital setting to another. And I'm sure others can speak to, it's really a difficult proceeding. But on the other side of it, end of life care can be really beautiful. And I haven't had many hospice cases, but I know I've spoken to other hospice social workers that just adore the work they do, because it's social work with a little bit less boundaries. You get to push the boundaries a little bit in order to make people's end of life care more special. And I know a lot of people speak to really enjoying that. So that's my 2.
I'd say that's absolutely true. And one of my first job experiences in my early 20s was at a large, like, for-profit hospice, and it did not go well. So you have to know kind of, I think, what you're going into. It was a lot of visiting people in nursing homes all day that were, their average length of people being in hospice was 2 weeks. So very end of life, and seeing people in nursing homes just day in and day out. It was really hard, especially for now. I realize that I'm a community-based social worker at heart. And that said, now in my, later on in my career, I've worked with many people in their homes, and it's just been such a different experience and so rewarding. And as people have been saying, a privilege to work with them. And there's so many different new models for end of life now. At our conference last year, we had a death doula come and kind of talk about that work. I know so much more about different models of grief, like David Kessler's kind of work. And I'm more spiritual than I was then too. So all these things I think have made a difference. So I do think you have to know what you're going into when you get into hospice. Yeah. And people are putting great resources in the chat too.
I'm just going to add, I love the conversation. I particularly love to have the lived experience and the provider conversation happening here as well. And for anyone that wants to speak a little bit more about thinking of level of care that suits you is what we just heard Cassie speak about, as well as always thinking about engaging, care partners and maybe hearing a bit about what that means, right? In engaging your care partner in this older adult journey, right? And with having Amy and Edith here, I'm sure that there may be a comment around that you may want to share, just in what that transition felt like, and for staying in place being an option, and it's not always a facility, right? And thinking of the role that social worker may play in that as well.
I would say that just like many of you were saying that you were an accidental social worker, COVID helped to make me become an accidental care partner, because it wasn't until COVID that I really focused on accepting this role. And I was working in academia, and so once the schools went online, it made it a very easy transition for myself to come home to care for Mom, who was still driving, by the way, at 95. And interestingly, she renewed her driver's license and her passport in the same year. And so she was still, very active 3 years ago. But during COVID, I wasn't quite so comfortable with her navigating by herself. So the transition as a caregiver was huge. And even though my background in academia was public health, and I thought I knew a great many things, but one of the things I learned very quickly is that there are very few resources for caregivers. And the system doesn't really reward caregivers. It penalizes caregivers for even bringing resources into the home of the person that you're caring for. And so that was a little jolting for me to make sense of, and it doesn't make sense. And I think there are tremendous opportunities for there to be more assessments for who's an appropriate, care partner overall. That the healthcare system seems to assume that if you're going home to anyone, that person is totally capable of assuming whatever clinical responsibilities can be assigned to them, and it's regardless of training or background. And my mom and I just this past 2 weeks, we mom received a prescription for oxygen and supplemental oxygen for the first time. And she doesn't have, she's a very mild case, but you also have to appreciate that my mom gets up and walks on a treadmill. So go figure, she's a little out of breath sometimes, during the day, right? The good news is she can still walk on a treadmill. And so, if she needs a little oxygen to make her more comfortable, we want to do that. But just trying to walk through that process and then discover that the primary care physician, because he failed to use the specific word oxygen concentrator, my mom was sent the wrong product. And so instead of receiving a portable unit, she was delivered these heavy tanks that she's expected to roll around while she's also using a walker. And it's like, who's thinking, and this is part of the, the daily crazy, of being, the caregiver, that keeps you on the phone when you really should be making lunch, but you're afraid to hang up because you've already waited, for 53 minutes and counting. And our situation was not resolved until I was on the phone, literally, no joke. I wish I'd made a picture. I had my mobile phone on speaker so that the social worker at the primary care office could speak directly on our landline to the provider's social worker, because they weren't talking to each other to make it happen. And I had to get them both on the line just to make that little administrative correction. And, thank goodness my mom wasn't gasping for air, because that whole process took another 2 weeks. She just got the portable unit yesterday. You see, and that's the kind of crazy, crazy, crazy that should not be happening with anyone. And that's why I'm saying, that's why I'm such an advocate, tell me where I can do the commercial so that you as social workers can get that communication network going so that these types of glitches don't occur. And, this is just one example of just, how skewed, the system is, and how there's such a tremendous opportunity. Your work is so significant. It's meaningful. It touches lives. And sometimes people get pushed down between the cracks and reduced to being something less than a statistic, but, for every day of delay, I mean, imagine if she had been in dire need of oxygen, that whole ordeal, cost us at least 3.5 weeks, almost 4 weeks. And I couldn't imagine, I could not imagine having having to look at someone you love go through deprivation over an administrative, oversight. Thank you.
Wanted to say, if I could, first of all, thank you so much to all of the speakers, Amy and Edith. It was so wonderful to hear your lived experience and to hear kind of from your perspective where the system is fragmented and needs some more work, and that, encouraging people to go into this field. It was wonderful. And we heard from such, wonderful, wonderfully diverse different ways that you can work with older adults. And I just wanted to say that it's such an amazing network of people in aging services, people that are supportive of others coming up in the field and supportive of each other. And I think, it's a testament to that, just the fact that all of the different schools of social work in Boston, kind of, not all of them, but several came together to do this event today. And I think it's amazing. And I want to just thank everybody, but also keep that in mind as you move forward in your career. If you reach out to people, it's likely that you're going to get a warm response and that they want to help you. If you're looking for jobs outside of Massachusetts, you're planning on moving after you graduate, you can also reach out to people because they likely have connections in other places and kind of can connect you to or guide you in terms of where to look in other regions to get started on a career search in that area. And so just my experience has been that the network of individuals in this field is just unbelievably supportive. And so I just want you to keep that in mind as you move forward with your career.
Absolutely. And thanks to Christina, Ambita, Bronwyn, and Sandra for all your help in planning this event. And we will be sending out the job links and as well as the recording. And thank you so much to all of our speakers. Wow. It was just wonderful to hear your perspectives and experiences. We really appreciate it.